The Pennsylvania State University campuses are located on the original homelands of the Erie, Haudenosaunee, Lenape, Shawnee, Susquehannock, Washoe nations. As a land-grant institution, we acknowledge and honor the traditional caretakers of these lands and strive to understand and model their responsible stewardship. We also acknowledge the longer history of these lands and our place in that history. Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison. It's my pleasure and privilege to serve as the host of the CGNE Seminar Series. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Long-Term Care Staff and Resident Risk Perceptions During the COVID-19 Public Health Crisis, will be co-presented by collaborating partners, Drs. Liza Behrens and Joan Carpenter. Before we begin the presentation, we do have some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continual Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. To earn contact hours, Zoom in and out time will be recorded, and the post-evaluation survey must be completed. So please be aware that the seminar is being recorded. If you have questions or comments throughout the seminar, please put them into the chat feature at the bottom of your screen, or you can raise your hand, and Jenny Rank is our wonderful assistant here, helping to watch the chat as well as unmute you if you're interested in speaking aloud. The post-evaluation link, Jenny will be putting that into the chat towards the end of the seminar after the lecture portion. You can begin it at that time, or you can do it after the seminar. We'll also email it to you, and you can do it ideally within 1 week of the seminar. And then your certificate, if you meet all the requirements for the contact hours, will be emailed to registered nurses within a month. If you have any questions about that or anything else, please feel free to reach out to cgne@psu.edu. Next, I'd like to introduce Takshila Dasahanke, who is a first-year PhD student, and she's affiliated with our center. And recently, along with many other graduate student affiliates, she participated in our 10th annual CGNE Alumni and Friends Spring Brunch. And we'd like to thank her for not only participating in that celebration, but for introducing our speaker today. Takshila, I think you're still muted. Perfect, thank you.
Okay. Thank you, Janice. Let me introduce today's speakers. Dr. Liza Behrens is an assistant professor at the Ross and Carol Neese College of Nursing at Penn State. She's also a Penn State Clinical and Translational Science KL2 scholar. Her research interests are in the implementation of preference-based person-centered care in nursing homes to ultimately improve the physical and psychological well-being of residents living with dementia. Her work explores how risk perceptions of nursing home staff, family, and residents influence honoring residents' preference for activities of daily living and care. Dr. Behrens' current work is focused on developing and testing a new person-centered risk management intervention to assist nursing home staff to safely honor residents' preferences for care and activities of daily living despite cognitive impairments due to aging or dementia. Please welcome Dr. Behrens. Dr. John G. Carpenter is an expert in geriatric palliative care, specializing in post-acute and long-term care settings. She is an assistant professor at the University of Maryland School of Nursing, a health scientist at the U.S. Department of Veterans Affairs, and a nurse practitioner with Coastal Hospice and Palliative Care. Her research focuses on implementation and evaluation of non-pharmacologic palliative care interventions to improve the quality of life, reduce symptom burden, and enhance decision-making for people living with serious illnesses and their care partners. Please welcome Dr. Carpenter. Thank you very much for joining us with us today. So over to you.
Thank you for those lovely introductions. Dr. Carpenter, she's going to share her slides with us. And while she does, I just want to say welcome and thank you so much for having us to talk on this topic today, long-term care staff and residents' risk perceptions during COVID-19 public health crisis. I would like to say that Joan and I have been working together for a little while now. We connected while we were doing postdocs at the University of Pennsylvania, and just found that we really enjoyed working with one another, and learned that Joan is a Penn State alum. So you never get too far. So thank you, Joan, for one, continuing to connect with me and work with me, and two, for supporting this work today. Okay, so we thought, well, first of all, we also want to say that, and I'm speaking for Joan too, as we've had previous conversations about this, is that this has really been a team effort. We have several people, which we will certainly acknowledge at the end, but we have wonderful research teams that have been working with us, both from the University of Maryland and from Penn State, and we have some collaborators at UPenn that's worked on some of this work as well. And I just want to say that this work takes a team effort. And so please know that while we're presenting it, we have many colleagues in the audience who have also participated on this work. Okay, so next slide, please. So first, we'd like to learn a little bit about you, the folks that are joining us today on this webinar. If you wouldn't mind, just place into the chat what role you have in nursing home care and what interests you about this topic. We're just going to give you a couple minutes or a few seconds to put that into the chat so we can learn a little bit about you and why you wanted to be here.
And Liza, I'll just join in a little bit as I have the chat up. Looks like we have a nursing student who's joined us today to learn more about this topic, which is great. A volunteer ombudsman, long-term care ombudsman, and advocate for residents' rights. We're so happy you're here with us today because we have like 80 participants today. We have activities director, nursing faculty, another ombudsman, area agency on aging representative, nursing student who's interested in the field. That's great. A first responder. We always like seeing our first responders because we know how much you are visiting nursing homes sometimes. Another ombudsman, great. Nursing faculty, rural health disparities researcher. Wow, we have a broad range of attendees today, Liza. Really coming to learn more about this topic, which makes us excited because this is the work that drives kind of our daily passion in our research and our teaching. So lots of nursing students, ombudsmen, and faculty. So I'll go ahead and mute if you want to move on to the next.
Sure. Well, you're certainly welcome to keep introducing yourselves into the chat. We think it's so lovely to have such a diverse audience. This topic has received really international attention. So clearly we're hitting on a topic that's needed to be addressed. So we're thankful for that. So for our time today, we were hoping to discuss some salient factors that will help support person-centered risk management in nursing homes during a public health crisis. And we could even talk a little bit about what that looks like now. We'll describe nursing home staff and residents' risk perceptions that may give insight into how they honor resident care preferences. And then we'll also discuss some implications of restricting visitation on nursing home staff's ability to honor residents' preferences, specifically ones around communal dining, group activities, physical and other activities and visitation. Okay, next slide, please. So just a little bit about how we came into this idea of thinking about resident and staff perceptions of risk in context of COVID-19. During the initial start of COVID-19, I was working as a postdoc, as I mentioned, at University of Pennsylvania, and also with providers beginning work around risk perceptions. And overlap immediately occurred as I was talking to healthcare leaders and nursing homes, trying to see what needs they had. It became very clear that nursing home leaders were struggling, especially right at the beginning, because this publication was right at the beginning, to address really the healthcare crisis. But in that, they were also challenged with specific needs of the residents. They were challenged by increased reporting demands from multiple governmental agencies. This probably sounds familiar to those leaders that are on the line. They were challenged with resource shortages, so resources not just in staffing, but in supplies. And they were also feeling a sense of abandonment, that they were just left on their own to deal with this crisis situation. And one leader aptly said, "We are alone in this battle." And so they perceived the need to know more about how best to manage quality care while still kind of dealing with this issue of depleting resources. So hence, we had developed a model in this publication here, which is a framework for coordinated response to COVID-19 in nursing homes. And this has really guided some thinking around this particular topic that we're talking around today, because a key aspect of that model is thinking about how best to still care for residents and meet their needs for needs and preferences for social interaction. Next slide, please. For those of you that have not seen this yet, this work also aligns with the National Imperative to Improve Nursing Home Quality. This report was released early this year. And a major goal in this report, and it did sort of reflect on what has been occurring throughout COVID-19, is that the first goal is to deliver comprehensive person-centered care that's equitable, that ensures residents' health, quality of life, and safety, promotes autonomy, and manages risk. And key to this is the first recommendation, which is to identify the care preferences of residents, residents and their chosen families, using structured, shared decision-making approaches that balance residents' preferences for safety and autonomy. So this is very challenging. Next slide, please. So to start this conversation, I'm going to hand it over to Dr. Carpenter.
Thanks, Liza. I appreciate that. I'm just going to keep track of time here and make sure we're cognizant of time and respect everybody's lunch hour that they're spending with us. So let's just start a little bit with, in March 2020, the CMS, the Center for Medicare and Medicaid Services, provided guidance for limiting COVID-19 transmission in nursing homes. And this was to protect residents and staff. But these measures, as we know, were meant to be temporary. And as we all know, as COVID continued, many of these restrictions continued into 2021 and resulted in prolonged restriction of social activities in nursing homes. Part of the reason I became interested in this work, along with Liza, is that I'm a nurse practitioner and practice in nursing homes, providing palliative care consultations. And it was very, very challenging to see people who were approaching end of life and not be able to have visits from their family members who previously were coming into the facility, providing daily care, feeding the resident, their family member, helping with their day-to-day care, taking them outside for walks. And then they weren't able to be with them at the end of life, which we know has been really hard for so many people throughout COVID. So this is a person-centered preference, right? Communal dining, group activities, physical contact, and visitation. And that's where a lot of my interest came in. And I think Liza, you gave us a great, introduction to person-centered care, but, knowing and honoring a resident's preference for activities of daily living is really important. And that nursing home staff were, citing the safety and health risks as barriers to assessing and honoring care preferences. And this, we saw as a huge issue that staff was facing. We know that previous literature indicates direct care nursing home staff personal risk-taking propensity influences how they honor residents' preferences, but we're not clear of the degree of how those risk perceptions influence honoring preferences, which has brought us to this research. So I think what we're going to do first is kind of have an interactive activity. Jenny, can you bring up our first poll question, and would like all of our attendees, all 80 of you, to respond to this risk perception question. Think about this. In your everyday life, how much do you agree with this statement of safety first? Totally agree, you disagree, or you totally disagree? So we'll give you a little bit of time to give us some responses here. And I am looking to see where the poll comes up. The results. Jenny, I might need your help with the poll question results.
Sure. Would you like me to end it? We've got about 80% participation.
Okay, let's give it about 10 more seconds. Maybe we can get to close to 100, but that's fantastic to have 80%.
All right, we're at 85. I'll end it here, 86.
Okay. Yeah, so it sounds like in your everyday life, most, people, well, there's a little bit of a split. They totally agree with safety first and they agree, but for the most part, people are agreeing or totally agreeing with safety first. Small minority of folks are disagreeing, but this is expected, right? So we know that most people say safety first. And so Jenny, can you bring up our second poll question?
Mm-hmm.
So our second poll question is that in your everyday life, do you view yourself as a risk avoider, meaning someone who avoids risks at all costs, or are you a risk seeker, someone who seeks risks regularly? And you notice we don't really give you much context for your risk taking here. So either a risk seeker or a risk avoider. And we'll give you about a minute here to respond. Maybe 30, maybe 45 seconds or so, Jenny. We'll see where we are.
We're at about 81% right now.
Okay, so maybe 10 more seconds and we'll end the poll. So yeah, most people are risk avoiders. That kind of goes along with safety first. Some people are risk seekers, which is interesting too. About 27% risk seekers, over 70% risk avoiders. So safety first and risk avoiders. So thanks so much for that, Jenny. What I want to talk about next is the risk propensity scale that we used in this study. And this is just basically the two questions that we asked you were based on the scale that we used in this study to help us to assess direct care workers' risk propensity. And you see that we asked you the first question, safety first, and that we also asked you the last question, I view myself as a risk avoider or a risk seeker. So the purpose of our study was to describe the nursing home staff's risk perceptions during the COVID-19 crisis as measured by the validated risk propensity scale, which I just showed you, and semi-structured individual interviews. And the purpose of the purpose of our research was really to answer these questions. And the first one was how do nursing home staff evaluate and attempt to mitigate risks associated with residents' activity preferences they perceive that carry a risk for contracting or spreading the virus that causes COVID-19? And then how do individual perceptions of direct care staff contribute to their evaluation and attempts to mitigate risk? And then our third research question is, how is visitation restriction during serious illness perceived by direct nursing care staff? So to answer these questions, we used a mixed methods study design with a multi-pronged recruitment strategy. And this study was conducted from June of 21 until April of 2022. About a year ago, we ended recruitment. And we basically were recruiting direct care nursing staff, and that includes nurses, LPNs, RNs, nursing assistants, social workers, and activity staff. And we used various outlets to recruit folks, and we primarily through social media, Facebook, Twitter, professional organization listservs. So basically everything was online, and we did encounter some interesting challenges with bots who bad actors who attempted to participate in the study who were not actually direct care nursing home staff, which taught Liza and I a lot about recruitment strategies and ways to mitigate potentially false participants in research. That's a whole other talk. We collected data through a demographic survey. Also, participants completed the risk propensity scale, and those people who were able to participate in a semi-structured interview did so. And we did have them participate off of work time, and that was done at a separate time to when they completed the survey and the scale. We analyzed the data using descriptive statistics, which we summarized demographics and survey data, and then we applied a content analysis to the interview data. So I'm first going to talk about our survey sample. We had 31 total participants complete the survey. You see a majority of folks were female, white, non-Hispanic, and then over 40 years of age. The mean age was 40 years. Roles, we had a really nice representation of activities directors, nursing at licensed and unlicensed levels, and then also social workers. It was a wide range of folks who, in their experience in nursing homes, ranged from 1 to 2 years to greater than 21 years. And all but one of the survey participants received training in person-centered care. And so what we saw in the results of the risk propensity scale is that they indicated, which is interesting, males consider themselves risk seekers, which is with a mean score of 5.8, and females consider themselves risk avoiders. But we, despite identifying as a risk seeker or a risk avoider, the majority of participants agreed with safety first. They preferred to avoid risk, and they viewed risks as a challenge. And I think we saw some of that today in our poll questions. We a lot of times agree with, most of us will agree with safety first. We don't want bad things to happen to people, especially to people that we're caring for as healthcare providers. We do prefer to avoid risk, and risks are a challenge. So you can imagine direct care staff, the challenges they were facing in the nursing home setting throughout the COVID pandemic and throughout these restrictions that were placed by mandates by CMS and the CDC. So I want to move on to talk a little bit about our interview sample. 24 of the 31 participants who completed the survey engaged in an interview. Again, the majority were female, white, non-Hispanic, at the mean age of 39 years, not much different than our survey sample. Again, our roles were spread widely with activities directors, nursing, and social workers all represented. So about 80% had more than 3 years of experience in nursing homes, which is interesting because, of the amount of turnover we typically see in nursing homes. But this could be, a little bit of a selection bias, because those individuals who want to participate in research may have a little more dedication and at staying kind of in the position they're in. They may have more job satisfaction. So lots of reasons there that we may be seeing folks with more experience in nursing homes. And all of our interview sample had received training in person-centered care. So just to talk a little bit about what we saw around direct care staff influences on preferences-based care during COVID-19, we found that nursing home direct care staff use their cognitive skills, their technical skills, and suggestions to take on the role of being an influencer when providing care to residents during COVID-19. They would use their cognitive skills to make decisions that involved balancing the risks versus the benefits to honor a preference. They discussed that they use their knowledge, they use current policies and procedures, interdisciplinary collaboration, and personal morals and beliefs to help make decisions to mitigate risk. They identified several sets of technical skills that they utilized to influence residents' care, such as teamwork, taking action to minimize risk of COVID-19, and educating others. They described working diligently to collaborate with the interdisciplinary team and to develop skills to influence care by minimizing risk to COVID-19. And doing that by enforcing facility policies and procedures, such as educating visitors and residents. They also discussed influencing care through educating, as I said, the staff family on risk-taking in the nursing home. And we also found that nursing home staff described suggestions for managing risks related to preferences as one way to influence the care of residents. Next, I'm going to talk about the factors that influence direct care staff decision-making around managing COVID-19, and that we found that organizational characteristics of the staff, family characteristics, resident characteristics, and the rights were certainly factors that influence decision-making. For example, organizational characteristics, one of the quotes that came from our participants: "To allow a resident to do their preference of wandering the hallway could potentially put this facility at risk for getting a monetary fine or not following guidelines of the CDC. Around education, they said education is key and communication. Around family characteristics, one participant said, I do think it's a risk, especially because their family members are out there doing their normal life. And when they're coming into our nursing home, they're bringing, potentially COVID-19. But we think it's really valuable they do see each other. But there is a potential risk when they walk in the building." Some of the staff characteristics, they talked about the massive burnout from all of the staff to where they could barely provide services, let alone provide activities, which were, preference-based. Some of the resident characteristics, one of the participants said, I've seen residents become secluded and isolated and develop depression due to not being able to be in their activities of choice or being secluded from family members and friends. So even though I think there's a risk involved, it's still important to have those options. And what this participant meant is those options to see family. One quote around resident rights, the resident has a right to choose to do what they want as long as it's not going to negatively affect another resident. Again, here, there's a lot of, moral and ethical questions about what is affecting another resident and other staff. And then our last major area of interest here were risk perceptions of compassionate care visits during COVID-19. And we found that nursing home staff described what compassionate care visits are throughout this time and when they could be provided to a resident and the impact it had on the resident, as well as the benefits and the risks surrounding compassionate care visits. And we found that compassionate care visits simultaneously expanded over time by supported by three themes. One, visits for those imminently dying. Two, visits to support psychosocial needs. So it just kind of expanded, and then visits to alleviate family concerns. And throughout these themes, we found that the benefits of compassionate care visits were improved physical and emotional well-being, and that outweighed the risk. At times, participants said that outweighed the risk of COVID-19 transmission, that improved physical and emotional well-being. That the risks of compassionate care visits were minimal when adequate safety precautions were put in place. And this is so, so critical because we know that nursing homes had less access to PPE during the COVID-19 pandemic, at the height of the COVID-19 pandemic. And then we also saw that we really need to highlight and consider the physical and psychosocial consequences of social isolation of nursing home residents while assessing the risk and benefit profile of compassionate care visits and viral transmission. So implications of this work, and there's lots of implications of this particular piece. We know that direct care workers are trying to avoid risk, and this is a direct reflection of what staff value. Unfortunately, nursing homes, came under direct fire during the pandemic with a culture of blame. We saw, nursing homes that were tasked with keeping residents safe, but weren't able to do so in the early months of the pandemic, came under scrutiny for protecting residents from risk by restricting visitation. It was almost like you couldn't win either way. So, I think I'm going to stop here and hand it over to Liza, and then we can continue talking about some of the implications of this work after Liza finishes her part of the presentation. So thanks, everyone.
Thanks, Joan. And absolutely. And as people have questions, please put them in chat too, so we can hopefully get back to them. And if we can't get back to them now, we will follow up with you. So I just want to start by transitioning our thinking. So now at the same time as we're thinking about, what are staff thinking about? I was undertaking a cultural ethnography in nursing homes to understand risk perceptions of nursing home residents living with dementia. And so this provided a really unique opportunity to also understand what the risk perceptions of residents were during this time period. Next slide, please. So I won't, same background as we had before, so I won't belabor this, but what we know is that nursing home staff had placed risk for residents' health or safety around every type of preference that a resident had. And this was prior to COVID. So next slide, please. What we also know is that there's dignity and risk-taking in older adulthood. And this is really important to think about when it comes to promoting well-being of older adult residents. What we don't know is what are the choices and risks of nursing home residents with ADRD. So we can easily assess preferences with older adults who have normal capabilities to communicate, but when that capability becomes limited, it can become difficult to understand what they would want or like, what their preferences are. And then that also potentially impinges their ability or their well-being, right? Next slide, please. Thus, the purpose of this study was to explore the perceptions of nursing home residents living with Alzheimer's disease and related dementias around risks with receiving preference-based person-centered care in nursing homes. Next slide. This was guided by a practice model, the preference-based person-centered risk engagement model, which is an evidence-based situation-specific model that guides shared decision-making with older adults living with dementia within nursing home communities. And congruent with person-centered care philosophy, it uses a social ecological lens to explain relationships between perceived health and safety risks from different perspectives in the nursing home community in the process of identifying and facilitating residents' preferences. Thus, we used it as a framework for this study. Next slide, please. So in our study, we, like I said, we're reporting on a smaller piece of a larger focused ethnography. In this sub-study, we used qualitative semi-structured interviews with nursing home residents who were currently living with a diagnosis of dementia. They were English speaking and continued to be able to verbalize, have verbalization or have conversations. And they had a preference that a nursing home staff perceived to carry risk to residents' health or safety. And we collected this data just after the opening of visitations in nursing homes between the Alpha and Delta COVID-19 variant surge in 2021. So we were right in the pandemic. We collected the interview data, the demographic data, and this nursing home, we were in a single nursing home, and the data was collected between July and September of 2021. Okay, go ahead, sorry, next slide. Data analysis. So we essentially, this was also guided by our theoretical framework, but we did 3 authors really independently reviewed transcripts. So we used a content analysis comparative method to look at and discuss what we were seeing in the transcripts. And we sorted codes, looking for patterns, identifying outliers, and organized codes according to the relationship to that preference-based person-centered care model we talked about earlier. We also ran some descriptive statistics on the participant demographic data. And we were very mindful to establish trustworthiness of data through triangulation, really with other data collected as part of the ethnography, such as observations of residents and also resident charts. Okay, next slide, please. So what we found, first of all, we were able to interview 8 residents initially, however, 1 passed before completing the interview. So we only had 7 completed interviews with residents. We had almost an even split between male and female residents. All residents were Caucasian with ages ranging from 73 to 97. We expected this given that this home we were in is a rural central Pennsylvania nursing home. What was most interesting is that the resident BIM scores range from 0 to 15. So significant, completely impaired residents to no impairment at all. And this is important because this is a measure that sometimes nursing home staff use to indicate whether or not they would include a nursing home resident in a conversation. Most residents self-identified as using, well, they also were, I'm sorry, I don't think I mentioned this. We also use the Mertens risk propensity score in residents. And you're probably thinking, how did you do that? We did go through a pretty rigorous process to create visual aids for the residents. And we also modified questions slightly so that they could respond. So with that said, residents themselves mostly identified as risk avoiders. I think we had 2 residents who identified as risk seekers. Next slide, please. Oh, and as just before I go on to the next step, you're okay. The preferences that residents had that staff perceived to be risky were around shower and bathing, food preferences, activities, and then walking and ambulation without assistance. So these were things during COVID-19 pandemic that staff were still struggling with to help honor these preferences of residents living with dementia. Okay, next slide. So residents participated in these guided discussions around their preferences and values related to their care and activities of daily living. Their preferences and values were often expressed through discussions of their personal encounters, experiences, or biographies. So for example, some of the preferences we talked about were shower and bathing, food and fluid, privacy while using toileting. We talked about ambulation and transferring, spending time alone, spending time with others, and going outside when the weather's nice. So throughout these interviews, most residents described attitudes and behaviors around avoiding things that will cause harm to themselves or to others, even though one resident described themselves as a risk seeker. So what you see here is that during these interviews, we picked up on 5 thematic categories. However, during these interviews, we did notice that residents would make context shifts, which is normal in dementia care, where they discuss their preferences of care, but they may revert back to a different environment. So for example, they may be talking about a preference in a nursing home context and then immediately shift to their home setting or being in a previous part of their life. However, we still were able to find 5 thematic categories across these interviews that could speak to how residents with ADRD perceive risks. And these include participation in decision-making, risk awareness, paying attention to safety, reliance on nursing home staff and family, and risk engagement impacts on quality of life and quality of care. Next slide, please. Okay, so we'll talk for a moment about our first category here, participation in decision-making. So residents described their personal preferences surrounding their care and activities of daily living. They participated quite readily. Residents described values where residents' values were often expressed through discussion of their personal encounters, as we talked about experiences and biographies. In regard to specific decision-making, throughout the interviews, residents discussed their participation in the process. This included times when residents just talked about experiences around exerting autonomy and independence to make decisions around their preferences for care. So, for example, one resident, when discussing their involvement in decision-making process related to their values and preferences, said, "I get the chance to decide whatever the situation is." Residents described wanting to have support while making decisions, particularly from nursing home staff. Some residents did say, "I get to choose sometimes," and some said, "I don't get to choose at all." So in all circumstances, residents didn't feel they had a choice or that they participated. Some residents described wanting to have support in decision-making, particularly from the nursing home staff. Next slide. So the next thing we found was that most residents described risk as that they were able to describe risk, and they had a risk awareness. And they described this as something to watch out for and not wanting to take risks with their health. Residents described being scared that something bad could happen to them. Things they described as bad included getting sick, having allergic reactions, sustaining a fall on the floor, a bump on the head, choking, going into sugar shock, getting into arguments with other residents, and being verbally or physically abused by others. What was also interesting is that they were able to describe good things that could happen to them as a result of having their preference honored. Some good things included feelings of happiness, goodness, cleanliness, being satisfied internally, learning something new, talking to people, having a sense of independence, successfully toileting, convenience in getting what they want when they want it. Additionally, residents were able to rate their risks associated with their health and safety on a range from no risk at all to the worst thing that could happen. So that was also really interesting finding for us here. And then very similarly, residents described what safety meant to them, particularly paying attention to safety. So residents describe safety as looking out for themselves and others. While some don't know exactly what safety is, residents describe their own individual safeguards that they put into place to prevent things such as injury. One resident described, watching out for others in their walking path so they didn't fall, but they didn't necessarily connect all safeguards to their preferences. Sometimes residents are aware, and sometimes they're not. So next slide, please. All right, and the next thing we learned from residents is that they rely on nursing home staff and family for different aspects of living. As we heard before, they certainly relied on nursing home staff for decision making. So they rely on families to provide resources, providing food, gifts, other things that they needed to be brought in from the outside of the home, and for visits to come visit them. There may be some tensions between, so the influence of families sometimes created tensions where around the decisional outcomes for specific preferences. So we did see that in some discussions that residents felt that the family, they needed to ask the family for something that maybe the organization wouldn't provide them, and that the family would then want to provide it for the resident, but we would create some extra tensions. So this needs to be explored more, but something that we found really interesting. Okay, so in terms of the nursing home, they rely on professionals and the nursing home organization to guide care. For example, they want staff to remind them to use their walker, choose the best way to bathe, those types of things. They express that the nursing home organization limits their ability to make choices about daily living, and that they felt they were not in control. Next slide, please. Okay. And our last area was risk engagement impacts on quality of life and quality of care. Residents discussed factors that impacted their quality of life and quality of care while living in the nursing home. They discussed how their risky preferences influenced, and they didn't use risky preferences, but they discussed how their preferences influenced their perceived quality of life. They reported that living within the nursing home can foster feelings of loneliness and isolation, despite their perceptions of quality of care. Some residents described their loneliness related to lack of family visits, as well as strict COVID-19 restrictions, which influenced their quality of life. For some residents, their perception of quality of life and care they received in the nursing home influence their feelings of wanting to leave or escape the nursing home. Residents discussed several positive and negative examples of engaging in their risky preferences, as well as living within the nursing home setting. Residents relied on nursing home staff to provide their care and meet their needs. And they discussed appreciation towards nursing home staff when they were helping them to take part in what they perceived as the risky care activities. Especially those that they weren't able to perform themselves, such as bathing or toileting. However, residents did discuss frustration surrounding the care they received Some examples included the resident wanting to engage in a risky food preference and staff not honoring that food preference. I think that was around potato chips at the bedside. Next slide, please. So in conclusion, and then we can kind of talk about implications together, results from this work can provide some considerations when caring for nursing home residents during emergency situations. We were just talking about COVID-19, the isolation and the loneliness, and the fact that their everyday care preferences still remain during that time period. I think another key learning from this work is that residents with Alzheimer's disease and related dementias can express risks surrounding their preferences and values, and should be included in care planning process despite what their cognitive level is. And then additionally, as a community, we must find ways, nursing home community, ways to include and honor residents in discussions around preferences for care and everyday living. Next slide, please. So these are our research implications, and I think what we'll do here, because the next couple of slides are I think around strengths and limitations. So perhaps we want to just talk about, well, first let's thank our team. Let's pull that up, and then also maybe let's talk about our next steps around this work and open it up for questions. Would that be okay, Joan?
Yeah. Thanks, Liza. So I just want to acknowledge, this is the team that Liza worked with in the study that she just presented. And then the team that we worked with between Penn State and the University of Maryland was really a unique gathering of folks. We had a couple internal grants that supported the participants being able to receive compensation or appreciation for participating in the survey and the interview. But then we also had several students working with us, which was fantastic. So, and I can bring up my acknowledgement slide in a little bit, but I just want to kind of emphasize how great it was to have a nice team of students and faculty working together from two institutions, and a great experience for all. Yeah, so
next steps.
So I think, I think Liza and I both agree, we want to disseminate these results to inform nursing home practices and policies around restricted visitation during crises. We're going to see more crises. I mean, unfortunately, this is just, the world that we live in. And how do we inform the decision makers in nursing homes on how to implement policies? I think, one of the implications when I think about from the work that Liza and I did together, that in the context of the CMS mandates and guidelines, staff were left to balance the risks on their own of restricted visitation and the benefits of visitation. And we know that the number one risk is disease transmission and death from the virus that causes COVID-19, and that 40% of the people dying from COVID were in nursing homes. So the staff really had to look at avoiding the risk of a resident contracting and dying from the virus by restricting visits, and they felt like they were protecting their home. But the benefits of allowing visitation, I mean, and I mentioned this before, by restricting a family's visitation, facilities lost an important source of support and assistance. And as I mentioned, family members often are feeding the residents, taking them out for walks, assisting with daily care. And those are really important activities. So we went from treating family as, we started treating family as visitors who were really an integral part of the care team for many residents. We also know that compassionate care visits, and again, that's kind of where I'm a little more focused, is that they were interpreted as special visitations for residents that were actively dying. And as I mentioned, it wasn't until about 6 months into the pandemic that CMS clarified compassionate care visits could be used for other situations, such as people experiencing severe isolation, decline, and depression. So those are a few things that I was thinking about. We're going to continue the data analysis. We are not done. So this is somewhat of a work in progress. We need to continue a convergent analysis of the staff risk perceptions to understand connections between risk propensity taking and the scores of the risk propensity and the risk perceptions. And then, Liza, I think this is more of an extension of your work here, the analysis of ethnography, if you want to speak to that.
Sure. So we'll also continue to do data analysis related to, we have some more data from our ethnography that we're working and analyzing now. And that's really to understand from the perspective of others in the community, direct care workers, nursing home leaders, family members, how they're influencing residents' decisions around risk preferences. So that's still in the works, and we hope to have that out for presentation probably by summer. We'll say too, in terms of wrapping up and implications, their nursing home leaders needed information on what was going on to be able to help them provide quality of care, through understanding the risk perceptions around preference-based care of both staff and residents. Nursing home leaders can make decisions on how much they should focus on that aspect of care, that they could still maintain quality potentially by while the sort of chaos is going on, having direct care staff really focus on the residents and knowing their preferences. And many did, as we heard in the first presentation. Okay, so let's open it up to questions, comments.
So we did have one question in the chat, is that would we provide the PDF of the slides? And I think Liza and I are absolutely happy to do so.
I would be curious to hear from the audience too, if they're, how they would use this information, what things they could use.
Mm-hmm. Right, what do you think you move forward?
Mm-hmm.
I was going to say, Liza and Joan, we have Virginia Gassel. She has raised her hand. So I'm going to unmute her or allow her to talk.
Perfect. Virginia?
Yeah, so she looks like she's still muted.
Oh, here
there
she goes.
is. Okay. Hey, Virginia, you should be unmuted at this time. Unfortunately, we're not able to hear you. So if you could maybe put your comment or question into the chat. Okay, while Virginia's working on that, I just want to mention to participants that, well, first of all, a very big thank you to Liza and Joan for sharing this incredible work with us. Really such an amazing example of qualitative research and how you really immersed yourself within the long-term care environment through your interviews and surveys and other strategies that you use to collect information and gain insights. Really through your presentation, it was very evident that you gained a deep understanding of some of the challenges as well as the positive aspects related to risks, and as well as some of the dynamics and cultural issues and things like that. So, just extraordinary work and a very complex time. So we really appreciate that. I'm seeing a couple of questions in the chat. Also some accolades, great job, Liza and Joan. Thank you for speaking today. Diane Barish is asking, what steps would you recommend staff and facilities to follow as far as documentation around decision-making autonomy in balance against potential liabilities from lawsuits should something negative happen?
So, Liza, do you want to go first, or this is a tough question?
So great question, Diane. I can always count on you for those wonderfully insightful questions. The short of the answer is yes, you should follow documentation, your documentation procedures. So first, you need to identify, right, what preferences residents are what residents have and ones that you're not honoring, and why. There's sometimes a very good logistical reason why you're not honoring a resident's preference, and that's perfectly fine, but that goes into the decision-making process. And there are wonderful tools on the preference-based-living.com website, specifically around risky preferences, where there's a care planning process that you could use and integrate. That's probably the number one and easiest way to integrate it into processes that you already have, is to use the care planning process as that documentation and making sure that you're pulling in all of the parties into that conversation. So, making sure that the direct care staff are in that conversation, making sure that the residents in that conversation, despite cognitive abilities, making sure that a family member's there, and then all of the key providers around that specific preference. So if it's a food issue with food, right, you're going to have dietary there. If it's an issue of, choking, you might need the medical staff there as well. And again, it becomes a negotiation, and the care plan document is a great way to document those discussions. So perhaps it's more than a quarterly, and I think most homes do this anyway, but more than a quarterly discussion, you might have to meet more frequently with some of these preferences to keep them going, particularly around maybe visitation when there's a high risk of COVID transmission. Let me see, what did I answer her? Oh, and in terms of legal liability, in some of the other work that we're doing right now, we're involving nursing home senior leadership, ombudsman, state surveyors, lawyers, in developing a process right now called Dignity, which is decision-making agent for dementia and autonomy, as you might have guessed, that we're recommending to communities, but that is not out yet for public consumption. So hopefully soon it will be. And in that group, we've learned that from a legal perspective, again, documentation is key, but conversations and relationships with the families are also key in having the community be prepared with their own standard operating procedures around decision-making and risk management. So I hope that gets to your question.
And Liza, I just want to add really quick, I've been in law, and as a palliative nurse practitioner in nursing homes, I've been involved in a lot of conversations around risks with preferences, because, a person wants to eat the kind of food they want to eat, and the staff is trying to figure out what are their care preferences, what kind of limitations on treatment may they want or not want. And so if we allow a person to, eat a food that is not, part of their prescribed diet, is that a risk of choking, but yet the person may be the person may be approaching end of life. And as Liza mentioned, the conversation is always so important. Having everyone sitting down, having an advocate there who can advocate both, on the nursing home side, but also on the resident side, that is somewhat of a neutral party, I think is really important. So really, we're so busy in this work, we tend to want to make decisions and move on, but sometimes it's taking the time to have those conversations that really gets to the heart of why this preference is desired and what can be done to try and meet that preference.
Those are awesome explanations about a very complex situation, balancing the risks of a situation with the potential benefits for the person, and that important conversation that needs to happen, as Liza was describing, at the interdisciplinary level, and then making sure that that documentation occurs not only in the notes, but in the care plan process. So thank you for all of those explanations. And I heard some of those, nuggets in your presentation and your research as well. I'm wondering a little bit about, you talked in your implications piece about helping share this information with the decision makers, the leadership in the nursing home, so that they can navigate some of these challenges in the best way possible for the residents. I'm wondering, because especially during the COVID pandemic, which was heavily regulated by CMS and the Department of Health, so many of the restrictions, nursing homes didn't have a lot of control over, until they did some revising at some point. I love, are you doing any work around, policy makers, reaching out to policy makers and informing them of some of this information to help guide them with so their higher level decision making?
So Janice, that's fantastic input, and we have not gotten there yet, but I think that's the next steps. Is to put this in the hands of the people who are making these decisions and understand who they're affecting when they're coming down with mandates, and without better guidance and without providing, I mean, we always back to, we know that nursing home staff felt if they had the proper PPE, the risks were mitigated with visitation and with communal activities. And it wasn't till later in the pandemic that nursing homes received the proper PPE that they needed.
Excellent point. Excellent point. I'm afraid we're at 1 o'clock. For participants, thank you so much. We had a great audience today. Jenny did put the link to the evaluation tool in the chat. If you haven't already clicked on that or copied and pasted it, please, a reminder to RNs, if you want contact hours, we do ask that you complete the evaluation tool. But thank you, Jenny, just put it back in the chat again, so it should be easy to access now. But for all participants, we really appreciate your feedback about the seminar, as well as other ideas related to this work. And again, thank you so much to Liza and Joan for sharing this incredibly complex and innovative work that you did that informs us, very well about risky preferences and the different perceptions that residents and staff in nursing homes had around this very important topic. So thank you so much for your time and sharing your expertise with us today.